So I can power. Just really want to.
Well, good morning, everybody, and thank you for coming. I really do appreciate everybody's presence today, participation. Okay. My name is Oscar Escobar. I'm the one that organizes all these meetings every month, if possible. Okay. I try to bring a lot of information for the patients. We have our own website. And when I said our own website, it's because I want everybody to participate on that. I want everybody to give me ideas. Maybe we can change things and modify or do anything that you feel like. Okay. On the meetings, by all means, bring ideas. I'm open to work with all around here, all in Naples, 4 miles, with all the doctors, try to bring doctors from anybody in the state, okay, to bring information to you because I was a patient, I was diagnosed with fibrosis, pulmonary fibrosis. I had a double lung transplant, so I'm a double lung transplant survivor. I'm grateful to the donor, to the family, to the doctors, and one of my purpose in life now is to pay forward what they have done. So this, what I'm doing right now, is for other people to get benefits from all this that we do. With that, let me introduce Denise Albert. She is an instructor, an educator instructor for Boehringer Pharmaceutical. She's been with us for many meetings. By all means, let's say welcome to them.
Thank you. So my background, I know a lot of you look familiar. So my background, I am a respiratory therapist. So I've been working in the cardiac and pulmonary realm for over 40 years. So I'm going to share some of my knowledge and kind of answer some of the questions people have. So today there was kind of two things that were kind of brought up. One of them we're going to be looking at is assessing those pulmonary function tests. We're going to kind of go over what that means and what those are. And also there was a little bit of a request for having to do with medication coverage, some of the changes that have occurred in 2026, kind of give you some of that information too, since we are here at the beginning of the year, okay? So the first thing I'm gonna do is we're gonna kind of have to be going through this. First page is, again, I am employed by Boehringer Ingelheim, which is one of the pharmaceutical companies. I am their clinical educator, and what I do is basically I work with people who have got some of these, what they call interstitial lung diseases, and I go over the pathophysiology of the lungs, what's going on with the lungs, maybe if they've been prescribed a certain medication, I go over those medications, and any kind of effects of those drugs. So that's what my job is. I travel every single day and work with patients 100%. I also do work with the offices, so that's kind of where we go from there. So again, this is nothing that is structured. If you have questions, let me know, and we'll go from any kind of question we have. So these what are PFTs? Pulmonary function tests. Okay, I think this is people are looking. This must be an echo on this thing. That's what we're hearing. So pulmonary function test. Pulmonary means we're talking about the lungs. Okay. Function of the lungs. How do they test that? Why do they want to be testing that? Anybody that's probably in here has got some kind of pulmonary disease, be it, an obstructive disease like COPD or a restrictive disease like any one of these 200 interstitial lung diseases. So what they do is these tests are used to measure the function or how this disease is affecting how much air you can get in and out of your lungs and the different flows. Common tests will include what they call spirometry. It will be the lung volumes or diffusion. These are all things that are doing. I'll show you as I'm going along here in the booklets what we're looking at. So we're pretty much right now on slide number 4. Okay. So what we're doing here is everybody starts with a different lung volume. okay, or lung, how much air they get in and out of your lungs. Quite obviously, a petite female is gonna have teeny tiny little lungs, so not as much volume to start off with. Versus, maybe a large male who's gonna have a large liter flow when they're looking at this. So when they're doing a lot of these tests, it's gonna be very specific for you, your size. So what they're looking at is your age, your weight, your height, your usually the size of the lung function that you're looking at. Okay. So what they do is they measure how the gases and the oxygen are exchanged in your body. So when you go in, if by show of hands, how many of you had one of these pulmonary function tests done? Okay, they're fun, aren't they? Wipe you out for the day. So again, these are probably one of the quickest ways to find out what is changing or what's going on with your lungs. Okay, and again, what they do, they can identify any abnormalities that are going on within your lungs. So there are a couple of different ways. This is going to be slide number 5. Again, when you're looking, if you have a booklet, the slide numbers are at the top in the green. Okay. So types of pulmonary function testing devices. So let's just say that maybe you're in a hospital and they're doing some of these testing. Sometimes it's just like a little mouthpiece that kind of come by the side of your bedside, have you do a couple little puffs and off they go. It gives us some basic information, but it's a kind of limited information. Other times they're what they call stationary devices. You go into a doctor's office, you're gonna put some little clips on your nose, and they're gonna have you do some different what we'll call parameters or different measurements, and that's what they're looking at. Okay. Other times when they want super duper reports, they are gonna put you in something what we call a body box. It's that clear glass box that they put you in, give you all kinds of elbow room in there, and that's for you to do this test. So what they are doing is they're going to be at one time diffusing different gases, and so it's very specific on how they measure these. So that's the one you're going to get probably more information, more detailed information. Has anybody seen one of these reports before? Okay, all right, a couple of you have. Okay, we're going to kind of go over some things because sometimes they're actually throwing numbers at you and you don't even know what they're really talking about. I want to kind of clarify some of that because this is a big part of your disease process, no matter what disease you have. Oh, okay. All right. All right. So pulmonary function tests, what they're looking at here again, what types of disease you have. So there are different types of disease in the sense there are what they call restrictive diseases and there are obstructive diseases. You hear a lot more about the obstructive diseases, COPD, chronic obstructive pulmonary disease, okay? And again, then there are other ones that are restricted disease. These are more of your interstitial lung diseases that have to do with the buildup of scar tissue. There are people who have both going on at the same time. But they determine the measurements of these diseases by these tests that they do, okay? So again, when you're looking at this, we'll kind of go over some of the differences. So if you have obstructive disease or restrictive disease, what you're kind of looking at and why they look at that. Okay. When you are looking at what they call, I'm going to say things that are normal. I don't mean like you're abnormal, but it just means, would I say someone who does not have disease, and we're going to call that normal, okay? So we start to lose lung function as we age, okay? One of those other things we start losing, okay? So probably maybe in about 35 years of age, you start losing some of this lung function as part of the disease process, the aging process, okay? So when you lose that, maybe something called milliliters. It's a very small measurement, but you maybe lose 30, 40 milliliters a year. It's something that's just consistent with age, okay? Some of these diseases, patients may be losing 4 or 5 times this amount on a yearly basis. Okay, so that's a big thing. So that's again one of what they're going to be looking at you. When they're looking at the decline of these lung functions, what they do is it not only affects us, it looks at the loss of flexibility in your lungs, how much they can expand. If you've got a restrictive disease, your lungs physically can't expand like they used to, okay? And then again, some of the muscles, diaphragm, which lays right down there at the bottom part where your lungs are, it's between you. When you get down here, it has to do with the breathing process. And even some of these diseases restrict the rib cage itself, how the lungs can expand. And so again, all relates to, how well you can get air in and out of your lungs. Okay, so now we are on slide number 8. So this says determining predicted lung values on spirometry. Again, this is what we were talking about. height, okay, your age, your ethnicity, male or female. Okay, so this is what again they're looking at this, and again these are what they call predicted values. So if you're looking at your report, there's going to be predicted values, what the actual values are. There might be some what they call bronchodilators, meaning anybody ever had one of these tests and maybe they had you either take a puff off of a little inhaler or something for them, okay? And then they had to repeat them again. They don't let you do it once. They want you to have 3 consecutive measurements, okay? Must be RT because you get yes. Yep. And so again, you see some of these. So again, it's not a one-time shot because they want to make sure consistently. Because let's just say they start to do a measurement, you cough. Okay, if you start to cough, then what happens is that's going to stop the machine, which means it's not going to be a consistent value. So that you're having you usually do maybe 3 consecutive what they call maneuvers for each one of these measurements they want to get. Depending on if it's that handheld device or it's this body box, they're going to have you doing multiple tests. Okay, any questions so far? All right. Okay, so what we're going to do is we're going to go on over to slide number 10. Okay, and this says commonly used pulmonary function test. So again, this is measuring how well do my lungs work. Okay, everybody's a little bit differently, but we want to know how well, can you inhale, exhale, and what the measurements are that you're getting. Okay, so when they do these tests, a lot of times they're maybe having you take complete brief breaths in and exhaling completely. Sometimes they're a little short, little fast ones. All of them have to do with different areas of the lung and how they may be affected. Okay, so during this test again, they want it specifically to be through that little mouthpiece, so they put little clips on your nose, and then they're having you do this kind of with a tight mouthpiece. Not the most comfortable thing, okay? I mean, I've tried to do them on myself, you know what I mean, tested. They are difficult for even somebody that doesn't have any kind of respiratory disease. But again, sometimes it makes you cough and you have different things going on, so it can be, somebody else want to come in? Oh, no. Oh, okay. He's slurring. Okay, all right. Hey, we're going to keep this down to a minimum, okay? All right. So again, the 2 biggest measurements that they're going to look at your pulmonary function test, it's going to be the one at the very top of the test. It's something called FVC, or forced vital capacity. Okay? That's the one where we have you take in a deep breath and then we start screaming at you. Blow, 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 blow. Take in another deep breath. So what are they doing? Take in a deep breath, expand in your lungs, see how much air can you get into your lung. Now, forcefully blow it out. Blow, 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 and then take in another deep breath. So how much air can we get in and out of your lung? The function of your lung, okay? So you see on the little chart here on 10, you kind of see all these little squiggly lines, okay? That's when you're just kind of taking those normal little tiny breaths. And then you see that big line that goes up and then way down. That's when we're telling you to take in that deep breath, breathe out. Now, even when they're doing that one test, they start extrapolating more tests from that. How much of that air could you get out in the first second? Okay, because this is when they start determining, do you have restrictive diseases or obstructive diseases? These lines look different, okay? Because think about it, if you have a restrictive disease, like an interstitial lung disease, you physically, those numbers can't get quite as high because you don't have the capacity to be able to take in that deeper breath because your lungs are restricted. Obstructive diseases, a lot of times you can get the air in, you can't get the air in. So instead of that air coming out really fast, it just kind of takes its time coming out of your lungs. So these are all ways that they can tell if you have restrictive disease, obstructive disease, or both. Sometimes they have what they call mixed disease. You get a little of this and a little of that. So that's what they're looking at, okay? So slide 11 starts looking at what, again, one of these interstitial lung diseases. So say somebody that has a restricted disease, okay? So what this says is when you're trying to get the air in and out, the volumes aren't going to be as high, okay? So you kind of see when you're looking at this graph here, you kind of see, so somebody always say normal without lung disease, they're going to be able to take that breath in, it's going to peak out, okay? Somebody with a restricted disease, they can't even get to that volume because they're not ability to even expand their lungs enough to get as high a volume into their lungs. So those numbers, the graph itself would look lower, okay? Same distance, but lower on that. So I would say that again. So again, reduced amount of volume of air that you can breathe in due to these interstitial diseases, okay? Let's go to slide 12. Okay. These are the kind of look at kind of a like a fun little graph here. So again, this one specifically concentrates on interstitial lung diseases, but I kind of just show you some of the differences. So you see where the line says normal again. So what you're doing here is, you see the graph, it kind of looks like this, okay? It kind of comes and it loops like this, okay? So it's opposite of what you're thinking. When you start to take in the breath, it's the bottom part, okay? So you take in the breath, take in a deep breath, it peaks up, the highest point you can take in. As soon as you start to breathe in, they being people with restricted diseases, they don't really have a restriction in the amount of air they can get out. So we kind of see that level, that line kind of comes straight kind of down like this, okay? So say kind of a normal person will be able to straight out. Somebody with a restricted disease, maybe a little bit of a different angle. You get people who have COPD, an obstructive disease, theirs is gonna look maybe not even as big, a deep breath in. When they're starting to breathe out, it's going, it takes forever. So it's like a peak, but then it takes really long. It's a really slow long because that air is getting stuck kind of in the lower parts of the lungs. They're not able to exhale as much. So remember when you're kind of in some of these pulmonary rehab, you start hearing things like pursed lip breathing. Remember, you can get the air into your lungs. You're having trouble getting the air out of your lungs. So what does this do? Slower and longer for you to get that air out of your lungs. It's allowing you to get all the air that you need to be getting out of your lungs. And that next deep breath can be a full deep breath again. Does that make sense? Okay. All right. So that's the differences when you're looking at those loops. All of this is if you ever ask for a pulmonary function test next time, you say, hey, can I have a copy of that? And you can kind of look at some of this and say, oh, that's what she was looking at. Okay, now I see the differences. Or sometimes you can physically see the difference. You can see if you cough and things like that. They'll have different things that look, abnormal. Okay, so slide 13 goes over what we call diffusion. Diffusion is how easy it is for oxygen to get in all the way into your lungs, into these things called air sacs or alveoli, into the bloodstream, and CO2 to do just the reversal. So every time you take in a deep breath, it's going in through your nose, through your mouth, into your windpipe, all the way into your lungs, into those little things called air sacs or alveoli. Everybody's got them. They're supposed to be part of your lungs. Those typically lay right near the bloodstream. It goes right through the air sac into the bloodstream. Your heart then pumps that oxygen through your body because everything in your body needs oxygen. Okay, then the CO2 is going to go just the opposite. There's a measurement that they do during this pulmonary function test called DLCO. It's the diffusion capacity. So what they do here is they just want to know gas exchange, how much air you can get in from the lungs all the way into the blood supply, and the reverse cycle. Okay, so what happens is, again, permeability of these little air sacs should be pretty easy. It should be able to go in and straight into there. With things like these interstitial diseases, what happens is the oxygen gets into the air sac. Now it's got to kind of work through scar tissue before it can get into the bloodstream. So it doesn't easily go through that little process. Okay, yep.
What's better, a higher number or lower for DLCO?
DLCO. So somebody that has no lung disease, it's normally not in the hundreds, it's usually about 80.
Correct.
Now there are some diseases that can cause that number to be higher, but typically it's about 80. So as that number starts to go down, instead of the bloodstream, I'm a visual person and I flail a lot here. The air sac should be laying right next to the bloodstream. A teeny tiny little space there called the interstitium. That's why these restricted diseases are called interstitial lung diseases. There's something wrong with that space. So what happens is, as the space gets further and further, as there's more scar tissue in here, that number starts to go down, meaning it's getting harder and harder to get where it needs to go. Okay, so there are certain things, so DLCO will go down as the space, the scar tissue is getting thicker and it's getting further and further away from the air, the alveoli and the bloodstream. Okay, so again, some of these numbers, people are like, well, bigger is always better. Not always. Sometimes these numbers are higher because you're trapping air in your lungs that we don't want to be trapped in there. So bigger is not always better in some of these measurements. Okay, but that is one where bigger is better. Okay, all right. And again, how they do these tests, some of them they'll have you taking in deep breaths, holding your breath if you can for about 10 seconds. You're breathing in a gas, and then what they do is they have you exhale it out, and then it measures the differential of the gases, and that tells what the diffusion is. Okay? All right. The next page, which is going to be slide 14. Okay, so slide 14 is what they call a 6-minute walk test. Anybody ever had to put a little, there we go, everybody. Put that little probe on your finger and they having you walking in the office, okay? So my advice to you is when they do these tests, okay, you want to mimic how you walk around day to day. Okay, and I mean sometimes literally it's a space this big. Okay, so if you kind of lollygag all the time, okay, then that's okay to walk like that. If you normally walk at a little bit of a faster clip, that's what you want to mimic. So what they are determining here is, in a measurement is, what is your oxygen demand? How much oxygen do you have available? And the activity you're doing, is it taking away too much of this bank of oxygen you have? Okay, they will not put you on, they measure it, it's called a pulse oximeter. Okay, it's a little infrared light that goes through that's picking up the red blood cells, the hemoglobin. How much of that cell is full of oxygen? It's usually they want it to be 90 to 100, it's a percentage. Okay, so 90 to 100% usually means that number one, doesn't mean you can't have shortness of breath, but it's probably alleviated pretty quick. Okay, as those numbers start to drift specifically 88%, at that point is when they would put supplemental oxygen on you. If you've ever been in the office or hospital, wherever they're doing the 6-minute walk test, if those numbers start to drift and they start to get kind of antsy, the tech that's with you, I would say, let's sit down for a minute, we're gonna put you on some oxygen. Okay, it's because that number was 88% or lower. Too much involvement of your heart and your lungs, put too much stress on those two organs when those numbers stay low. So they don't want them to get that low. Okay, they don't want that because the lower they get, harder it is to try and get back up to those levels, say acceptable levels, which is right around 90. Okay, so they'll do that. They measure the distance that you walk, they time you for 6 minutes, they check your oxygen level, okay, and throughout. And if for any reason, again, it dips down, then of course they would recommend oxygen, and that's directly related to your pulmonologist. Any questions there? All right. So we're gonna go over why do they do these pulmonary function tests? How often do they do them? Okay. So really not a timed sequence of this, okay? People that maybe have an interstitial lung disease, those patients, this disease is a progressive disease, okay? It can be sometimes very progressive for some people, maybe every 3 to 6 months is an average. Other people, like I go into the doctor's office, they do it once a year. They get a baseline and then they want to kind of find out what's going on. If they see some pretty maybe big abnormalities from one year to another, a pretty big decline in maybe the disease itself, then maybe they're going to have a CAT scan or something else, or chest x-rays done to see, is there some pneumonias in there? Is there something going on the interstitial lung disease side? Is more scar tissue building up? There's usually a reason for this, okay? Which is why they don't have you do one single maneuver, they have you do multiple for each one of these measurements. And they compare them. They're going to compare them to what was done before. So if they start seeing differences, so let's just say that you hear somebody say, okay, your lung function is 70%. Okay, I'm just gonna throw that number out there, because usually what they're telling you is 70. You got the predicted, you got all those numbers, but if you ask the therapist, what's my lung function? Usually what they're talking about is the forced vital capacity, on average. And what that means is that they're telling you, again, remember we talked about, those 4 measurements that they kind of, at the very beginning here when they're saying, how are they comparing mine against somebody else? So what they are doing is they are going to take somebody of the same height as you, age as you, ethnicity as you, and sex as you that does not have lung disease. And they're going to make a comparison. So let's just say if they said you were, let's say 80%, that would be basically you have 80% of the lung function compared to that person, 20% less lung function. That makes sense? So if they were, okay.
So I'm looking at my test right now, and it's, the value they give me is in liters.
Yep, so liters is the volume of air that you can get in your lungs. So let's just say a male might have 6 liters initially or something like that, depending on how big your thing. So And then usually they'll have a percent predicted. Everybody measures them a little bit differently. So what was your liters? That's usually your total lung function, your forced vital
This is an old test, so it's 2.08 liters.
Okay, so 2 liters. That's
Yeah, so how do I convert that into that?
Is there not more measurements after that? I'll sit with you specifically and tell you how to do that. Or do you do pulmonary function tests?
Oh, I do, but it's been a long time.
Okay. Yeah, it's only been about 25 years for me, but but it's okay. It will get a percentage. So what they do is they're basically taking your total lung capacity, which is how much air, total reserve volumes, everything, and then they're giving you just during that course, meaning that maneuver, what the percentage was. So
Okay.
yeah, I'll get it for you. But again, that's kind of what they're doing. So they make comparisons. So if they did one in January, okay, and you were 80%, okay, specifically for that one. And let's just say in 6 months or a year, they repeat it again and you're 76%. They would know in that period of time, you've lost 4% of your lung function. Again, how much air you can get in and out of your lungs, okay? So that's how they kind of determine this. This is one of the determining factors that they do on how they track the progression of the disease and what's changing and the management decisions. Do they need to maybe be changing you medications? Is there something going on? Is there infection? Is it disease progressing and maybe they need to change your medications? Or is it just part of the process itself? So again, not really a time sequence for this. But this is just kind of one of the tests because I know, a lot of you go in and get these things done. It's like, yep, I just got it done. And they say it's okay or whatever. And you don't really know what they just did or why they keep doing them. This is why. It really tells them one of the quickest ways to determine how your disease is progressing. And again, not really a time when they'll do it, but they will take it from the one before. Okay. Any questions on pulmonary function tests? Yes, sir.
Is there anything being done to reduce the interstitial space?
You can't, but not if you have interstitial lung disease. The scar tissue is building up in that space. They can't. If you had a total lung transplant, that's the only way to get rid of the scar tissue. There's nothing that can be done.
And is it possible to have your results improve from 1 year to the next?
Okay, so there can be a couple of things. Some of the things, especially like the forced vital capacities, sometimes they can be more effort driven. Okay, let's just say you really had a bad day. Okay, you weren't feeling good or whatever. They can dip down a little bit. Usually within, meaning it's going to be a close percentage. Okay, which means sometimes medications that they give you can advertently increase sometimes the volumes, that the ability for you to get air in and out of your lungs. So sometimes it can be a little effort dependent, and then sometimes it can be medication driven.
If I may,
Yeah, absolutely.
if I may, give you some of my insights. To me, after the lung transplant, they do it every month. Every month, they'll do it. Sometimes they do it twice a month. And in addition to that, I do have a little device to do it at home that I have to do it every night or every morning, whatever I choose. So I do it once a day, and I compare my numbers to their numbers. Something that Tom just mentioned, or Denise, if you have, for instance, I had in Thanksgiving, I had a little bit of cold that one of my kids brought from the school, okay? And it lasted for me, in particular, after that, it lasted about 3 months, okay? Every person that have a lung transplant is more prompt to have this disease drag for months, okay? And my numbers were completely down. They were down. I was at 2.90, in between 2.80 to 2.90. And it went down to 211 to 212. And it was just like that, little by little increasing. But it was because of something that you have is going to bring this down. So you need to be very careful when you have colds or any other
Well, my numbers went up
okay.
year after year, and I'm wondering if it was related to exercise, weight reduction.
The exercise,
Mine would go up,
the exercise helped.
you know, it's going down.
Yeah. Yeah, and again, it depends on which one of these numbers you're talking about.
I don't know.
Yeah, I mean, they could be looking at a lot of different numbers, but sometimes there could be different numbers for different reasons. Yes.
You know what, one thing I learned on function tests too is there's a learning curve on how to do the test.
Yeah.
Okay, and that makes a big difference, because the first one that I got, I mean, the tech was pulling her hair off because I couldn't understand what she wanted, okay? But once you start doing them on a regular basis, you develop a technique of it. So I don't know that that really spikes it, but it helps it go in the right direction. You know what I mean? Maybe another question, there's 2 other tests you didn't mention that I get pretty much, I go in every 3 months for a battery of tests. One is titration, oxygen titration, where you go on the steps. And the other is arterial blood gas, where
Yeah.
it's a blood test.
Yep, I used to do this.
Okay, what are those, what's significant about those different than
This
the
is pulmonary function
measurements
test?
of pulmonary function and 6-minute walk?
Okay, so the titration has to do with the gases used. Are you talking about are you in a box or something like that?
I'm in the room, but I go on steps. I have to go up steps.
Not quite sure.
Are they testing your titration on your oxygen?
Is that what they're?
Yes,
Oh, okay, okay.
So they're just checking to see when you go up the steps, is the oxygen that you're on efficient?
okay.
And so that's why they're titrating. Can we lessen the oxygen or do we need to increase the oxygen?
Okay.
So
Yeah, 'cause
that's why.
yeah, steps are one of the most difficult for people. I mean, patients that I work with every day, I mean, that's a trigger. If they're gonna get short of breath, it's typically, guess what? You're using a large muscle. A large muscle demands more oxygen. Remember that oxygen kind of bank, I'll use that kind of term. The oxygen you have available, it's gonna demand more. The biggest thing I can say with anybody that has any kind of lung disease is stay active. Okay, you have to stay active. If you feel like you can't stay active, then you need to be doing things like pulmonary rehab and these kind of sessions. This is not just coming in here and exercising, okay? This is a mental and physical diseases, you know, and sometimes people get scared. If they get short of breath, they're scared, they don't know, do I push fast? Do I stop? When do I know when to go and stop and I don't even know what to do? These guys are the experts. They're the ones they're making you do different tests, sometimes just working upper body, seeing what your oxygen levels do. Lower extremity, what are your oxygen levels do? Now I'm gonna have you doing something with both. And do you, what they call the saturator, do these numbers go down even more? So that's specific, just like this is doing, is determining are there certain activities that cause these numbers to plummet even faster? And if it is, then maybe we need to condition that muscle a little bit more. Yeah,
How
yeah,
about things like breasttree that you might use? You know, like let's say you use it in the morning and in the afternoon. That's a positive thing, I guess.
is that maintenance medication? How often do you take it?
Once in the morning, well, I take 2 puffs in the morning and 2 at night.
Okay, so those are what they call maintenance medications, meaning those are medications you stay on all the time. There are things called rescue inhalers, Ventolin, albuterol, Preventil. Those are the inhalers you take and they act very quickly, but they don't last very long. But if you're having an incident where you're all of a sudden extreme shortness of breath very quickly, they give you the inhaler, those kind of inhalers. That's what they call a maintenance medication. It keeps your lung disease hopefully in kind of sync a little bit more than for doing these. They want it to stay more steady. They don't want these big dips and you know, low points.
And maybe
Yeah, yes, sir.
I have COPD
Okay.
along with other things. They tell me that my lungs are worse than my heart, even though I have congestive heart failure and I have other things wrong with my heart as well.
Okay.
But my oxygen level has always been good.
Yep.
And when I did the 6-minute walk here, the last 6-minute walk, my oxygen level stayed at 96.
Yep.
And I walked as fast as I could.
Okay.
And that's not normally how I walk.
Okay. And what's your question?
I do get short of breath.
Yep.
And I use my inhaler. I have a rescue inhaler and I have a maintenance inhaler.
Yep.
The maintenance inhaler is the one that helps me the most.
Right, that's what he was talking about, something you're on long term.
Yeah, so I take 2 puffs in the morning.
Yep.
And 2 puffs at night.
Mhm.
Sometimes I don't take those 2 puffs at night because I sleep in CPAP.
Okay. Yep. Oh, so you got sleep apnea or either You have,
Yeah, I have.
see, we're going from one thing to another to another. It doesn't take long to start adding
Yeah,
these
you
up.
don't wanna know everything is wrong.
Yeah. Yeah. Well, just to kind of let you know, so heart disease and respiratory disease, pulmonary disease, run hand in hand. Okay, that's why a lot of times when you first get, maybe diagnosed with some of these respiratory diseases, they have you go see a cardiologist because they look pretty similar. To be honest with you,
So they say that I can't have open heart surgery
you're welcome, sweetheart.
because of my lungs.
To compromise. So what they do is, I literally have found some patients that over the years, their oxygen levels and the CO2, the waste products are almost even. Okay, they should not be, but people compensate for these diseases so differently. There are some people who their numbers can be horrible and their bodies are just compensated to where they're not very symptomatic, okay? Other people, very minimal changes and they're very short of breath. So what it's telling you is the amount of oxygen, those little the little vessels that are carrying the oxygen, okay? The ones that you have available are full of oxygen. Some of these diseases destroy the capacity to get it in there, which means there's not as many available. So the ones that you have are fully saturated, but some of these diseases, you don't have as many of them available. So you can still
They
get short
haven't explained it very well.
Yeah, you don't have as many available to give you more oxygen, but the levels that you have are high because they're saturated, the ones that you have. I don't know if that makes sense. We start getting some pretty clinical here, but yeah, that's what it is. Yes, sir. Oh, I'm sorry. Let me just grab this gentleman over here first. Yes.
So I have COPD
Okay.
with a associated complication
Okay.
called
Very
pulmonary
hypertension. Okay.
ataxia. Pulmonary ataxia.
And what is that?
So that is a weight loss, steady, aggressive weight loss. Not enough oxygen getting in. Body needs energy,
Right.
so it steals fat, muscle
Okay.
to get that energy.
Okay.
So I've lost, for example, 30 pounds in about 9 months because of that.
Okay.
So I was wondering if you're familiar with this, what are the best things to do to stabilize the weight loss?
Do you have a nutritionist?
Um,
Okay, I mean, I can't give you medical advice, number one, but number one is I would probably say get a nutritionist involved. Because people who have these respiratory diseases, they can burn a lot of calories by breathing. Okay, you know when you get short of breath, the shoulders start coming up, the respiratory rate gets more shallow, you start breathing harder and faster, and these are all things that burn calories. Okay, and what happens is some of these diseases, you lose your appetite, which means that you're not consuming enough calories and you're burning more than you're taking in, so you lose weight, and specifically you start to lose muscle. So a nutritionist can give you recommendations on if you need to concentrate more on proteins to keep the muscles active. Carbohydrates sometimes can cause, that's a whole other talk we'll talk about, but there are different things that you can eat and that can kind of help with that. So a nutritionist, a lot of times your physician can order that and they can go through some of those Medicare services. Let me just grab this gentleman and I'll grab you. Go ahead, sir.
I'm just curious, have you seen more COPD since COVID?
I don't know if I would say that, but I work more in the restrictive lung disease realm. And there is definite data that is coming out now that there's some of these cases potentially could cause some of these interstitial diseases. There's more and more data. We're all guinea pigs. We all are. I mean, they're still collecting data and we don't know what COVID did. But I'm sure they'll continue to get more and more. I think they've seen a big spike in a lot of these respiratory diseases, probably directly relates to a lot of vaping and stuff. Some of these things, younger people are just getting some of these diseases that should not be in young people. So I don't know this gentleman first. Okay, go ahead, and then I'll grab you. Okay, go ahead.
Actually, I have comments to follow up on both of these.
Oh, you only get one. Okay, no, okay, go ahead.
No, with respect to that, the issue about COVID, my pulmonary fibrosis is completely manageable. Then I got COVID, and it just knocked it into it. this gentleman, this raises a question. I had a situation where I was using weight medicine and having reduced appetite. And, I attributed wrongly to basal
For pulmonary hypertension.
doctors have told me it was related to OPED, but even though I've been on it for years, that apparently late development side effects can occur on.
Okay.
But this gentleman says, based on what he says, now see, this is also another condition, so this now uses me as to whether it was a side effect or something. I'm now back on OPED for the lower dose, and I don't have those effects, but I have greater shortness of breath.
That's a medication.
It's for pulmonary fibrosis. It keeps,
Yes,
keeps the slowness of the development of the fibers. Straight breathing.
So again, some of the weight loss can occur in some of the disease states. It can cause loss of appetite. Some of the disease states, it can be medication induced also.
I have a question regarding somebody I know. What does it mean when the interstitial lung area fills up with fluid?
Okay, two different things going on. So interstitial lung disease has to do with fibrotic changes. Fluid in your lung can be more of something like a congestive heart failure kind of issue.
It's an interstitial area.
The interstitial area with these diseases is filling up with scar tissue.
No, it's liquid.
Not quite sure. I'd have to,
Okay.
yeah. Yeah, I was saying this unless it's some kind of infection going on, but I can't. Yeah. Okay. I know we're at time and I don't want to take up, I've taken up everybody's time here, I'm sorry. And then one last thing is I think it's important because some people mentioned this, okay? A lot of you are on medications, and this is specifically by request, okay, that there is new plans that went into effect as of 2025, okay? These are regarding Medicare Part D prescription plans, and I'm not gonna go into this, but I just want to tell you, the 2026 guidelines for anybody that is on a Medicare Part D plan, it did increase so that maximum out of pocket, anybody that has a Medicare Part D plan is the maximum out of pocket is $2,100 for the combination of all your medications. Once that has been met, all of your medications are 100% covered. Okay, so last year it was $2,000. If anybody notices you were paying for drugs and all of a sudden your drugs were nothing, that's why you had hit the $2,000 mark.
What if they send, Social Security send you a thing saying your Part D is $1,300 off of your, for your medications?
Then it means you've probably already sufficed $700 of it.
No.
Okay, our Social Security is a different animal, and I'm not gonna go into different plans because I don't do anything with insurance.
Yeah, well,
Yeah.
I was on a regular,
Yeah, you get this Medicare Part.
plan, and then I had switched to another one.
Yeah.
So the two combined are $2,100,
Yes,
but one's $600 and one's 13 something.
yes.
So that's like $2,100.
Yeah, the 2,100 is the maximum out of pocket. I just wanted everybody, because people were asking me, what's the deductible? That is what it is. It went from $2,000 to $2,100, and it specifically assists patients who are on drugs that are these rare lung diseases that they have. COPD is not really considered one of the rare lung diseases, but these interstitial lung diseases are rare diseases. Yes.
Yeah, Medicare does have a plan where you can amortize that out over 12 months.
Yes, it's called smoothing, but that's new also. Used to be you had to pay for it up front. Now they've allowed to where you can take that $2,100 for some insurance companies. Yes, sir.
I have a drug-related question. My pulmonologist told me that there is an alternative offer that has just been approved. But when we were discussing it, he said but it's been approved only for idiopathic fibrosis and not for fibrosis due to other causes.
Okay.
If you have any information about that, you can.
Today's discussion, I do not talk drug related, but you are correct. There is new indications for a new medication that has been released. And your pulmonologist is very aware of that. And there are now, it does cover 200 diseases. It does cover all the
It
diseases.
does cover it.
Yes, but I'm not gonna talk about drugs today. I can't talk about a drug and then a non, what they call something that's like this, I can't talk about it. But no, you're good, you're good, I just don't wanna,
General drug question. When a drug is developed, it's given a brand name.
correct.
When does it go to generic?
When
When
a
did
drug,
they lose that proprietary?
when a drug is going under investigation, there is a time that is set, I believe, and I don't quote me on this, I might be the FDA.
17.
So what it is, they'll give you a number of years for you to develop the drug, if you can get it to what they call market, meaning it passes all the clinical trials, and sell the drug for a certain amount, it's so many years. But again, if it took you 15 years to develop the drug and it was for 17 years, you have 2 years, that's it, to sell the drug, and then it goes generic. So it depends on what was issued when they first tried to go for a specific drug.
How can you find out when the drug is coming off the patent?
Probably have to call the company. I only know for the drugs of maybe. But definitely, if it was like Eli Lilly or Abbott or something like that, you probably could call a 1-800 number and ask.
That's Siri.
Baby, AI is part of everything. All right, any other questions? I'm sorry I stole everybody's, I took your hour up.
Which is fine. Thank you, Denise. One thing that I want to bring to the group, and I'm always fan of the clinical trials. I know that it sounds scary, but if people don't participate on the clinical trials, we won't have new drugs, new medications out. Okay, so I was just recently, actually yesterday, I was contacted by Mayo Clinic to see if I wanted to participate on a new clinical trial for pulmonary fibrosis. Unfortunately, I told them for my benefit, or fortunately for me, I have my double lung transplant. Unfortunately for yourself, I cannot participate. And they said, yes, if you have your double lung transplant, you cannot participate because technically you no longer have the pulmonary fibrosis. But again, there is a lot of clinical trials out there that you can participate. Actually, Dr. Sanchez, they do have a clinical trial that they're going on. And there is some other ones that I put on the website. And if anybody's interested on the one that I received yesterday, I got all the information and the consent if anybody wants to have that.
People just have to be aware that in most trials, there is a placebo group.
50-50.
So you can very well not get the drug.
50-50. It is true. And as a participant on these clinical trials, for a fact, I know that on my first clinical trial, I was on the medicine. I was on the medication.
You feel different.
I felt the different. I was just doing my exercises without oxygen. I was feeling a lot of energy. When they finished with that clinical trial, I got enrolled in another clinical trial, which was the one that Boehringer bring up the new medication now. Unfortunately, on that one, I was on the placebo. So yes, and you feel the difference. By all means, you feel it.
Can you go back on the first line?
No, it's once you start participating on this clinical trial, they just provide you with the medication, okay, until they finish with the clinical trial. On the clinical trials, let me just give you a little bit of information. They pay you for your time. They pay you for your transportation. If you need to be on a hotel or have meals during the We pay for all that. Okay. So by all means, if anybody needs to have some information on our website, I got a lot of the information for the clinical trials.
If you do a clinical trial in around the placebo, do they allow you to get the extra the individual trial?
When they approve the medication, yes, of course, they go to be on medication, yes.
Thank you.
Anybody else?
You just have to get one. No, thank you. I'm just looking for
Yes.
Well,
the one circle
idea.
that they're talking about. They have one where you
Actually, when it's going to be.
No,
one particular thing.
no, there is multiple clinical trials going on right now. From different pharmaceuticals. And I have some of the information on the website for the clinical trials, where you can look at it and ready for those clinical trials. You can ask your doctor, because I don't understand why the doctors are not of participating in the clinical trials.
So they were having a clinical trial where I go, NCA's favorite,
Okay?
and my kids, my cardiologist said, no. You're not going to put it out.
Yes, you need to talk to all the doctors about the participation in the clinical trials.
I'm not sure everybody. Yes.
Yes, I believe that. Yes.
Here. Go ahead.
So with this, I'm just gonna take a couple more minutes. I just wanna say thank you to Denise for running details and all the lecture. Okay? And I wanna let you know that these meetings are in conjunction with Rescues and Values, which is another organization that I just participate and maintain. So with all the support and the support from NCA and Denise and everybody, all of you, that's what we have in all this meeting. Thank you very much. Now,